Logo fades into view. New York Association on Independent Living. Thank you to our 2022 webinar series sponsor, Waymo.
Okay, it is 1:02 and we've got about 80 people here. So great interest in this webinar. Thank you all for joining us. For those that don't know me, my name is Lindsay Miller. I'm the Executive Director at NYAIL. I'm just going to start with a few housekeeping things and then I'll turn it over to our presenter. So for today's webinar, we are in webinar mode. So in terms of questions and answers, we have the Q&A panel that people can use, or you can chat directly to the host and panelists if you have questions. Generally, we tend to take questions at the end of the presentation, but I'll let Val decide how she wants to handle that as she goes through the project that she's presenting on. I also want to just take a minute to thank our sponsor, Waymo, who's sponsoring this 2022 webinar series. So today's webinar is on the Managed Long-Term Care Data Transparency Project. We'll be hearing from Val Bogart, who is the director of NYLAG's Evelyn Frank Legal Resources Program, who spent a great deal of time and effort gathering data from managed long-term care plans from several years and putting it into a digestible format so that advocates like us can take a deeper dive, analyze the data, and use it in our efforts moving forward. So I know many people are really excited about this and looking forward to today's webinar with you, Val, to get a deeper dive into the website and the data that's available, and then to talk about next steps and how we can work together to use it and to build on it in future. So I'm going to turn it over to you.
Okay, great, Lindsay, and thanks to NYAIL for inviting us, giving us this opportunity. So I'm going to share my screen. And go over to the website. So, this webpage is a part of NYLAG's own website. So the URL is at nylag.org. A lot of you are familiar with NYLAG's the other website that we co-maintain with the Legal Aid Society, Empire Justice Center, and that's at NY Health Access. If you get lost and you find yourself there because you use that site so much, in our MLTC update article, there will in the news, which is always in the news area, you can always find a link. There's popular links here. You can always find a link here to the Data Transparency Project. But the URL is pretty easy to remember. It's just nylag.org MLTC Data Transparency, all one word. But you might want to bookmark it and make a note of it. Right now, it can be found from the home page of the NYLAG website. If you just go to nylag.org and go down, because it's a news item here that we launched this project. But I don't know if that will always be right there on the home page. I wouldn't count on it. We're working on making sure it's easy to find from the NYLAG webpage. But for now, you can find it there also. So just a few acknowledgments to start off before we get into this. This project was funded by grants from the New York State Bar Association. I think I saw Judy Grimaldi on the list of attendees, who I thank the Bar for a generous grant, and the Fan Fox and Leslie Samuels Foundation. And we did it in cooperation with a company called Public Signals, whose owner and director and entire staff is I believe, here with us, John Rodat, who if maybe we'll be able to figure out a way for John to pipe in. And big thanks to Eric Smith, who was a volunteer law intern, and we couldn't have done this without him. But so this was a massive initiative and ended up being a lot more than we realized. It took a lot more than we realized. So let's just start with some background. I think everyone here knows what managed long-term care is. It's New York's mandatory method for how Medicaid recipients who are adults who have Medicare and Medicaid can receive most Medicaid home care services, whether that's personal care or consumer-directed CDPAP or private duty nursing, and also adult daycare. If they need any of those services, they gotta go through MLTC. And there's now 300,000 New Yorkers in these plans. It's quite a huge business. I understand there were about $15 billion paid to plans last year for providing these services. And the real purpose of this project was to expose data that the state collects every quarter from plans called cost and operating reports. In other words, managed Medicaid cost and operating reports. MLTC plans file it, mainstream plans file them, HARP plans, they all file them. And we'll look at a sample so you see what's in there. And there's so much there. But the state doesn't share any of this data. You have to get it through a Freedom of Information request. And then it's very difficult to figure out how to compare plans. So we have done that with some of the key data, which is what we're going to show to you. But it's financial data, what income do the plans get, what are their capitation rates, we'll show you. These are some of the big secrets, right? And nobody knows really how much do plans get. Well, we'll show you how much plans get. How much do they get in the extra add-ons for recruitment and retention of workers? And how much do they spend? That's the key thing. And on what? So the state doesn't share this, all right? So just to show you what, we're on the home page. We have some of our big demands based on the data, but our whole report, I urge you, if you have, so if you want some evening reading, to download the full report, which has these recommendations and much more, and a lot of neat graphs that are downloaded that we're going to look at now. But here's some key things also that I want to show you that you might want to look at more closely. The first is a sample of these reports. Like, what do these reports look like? So here's, I don't know how to stop these pop-ups. So here's what these look like. Now, this report is from 2018. You can see it wasn't filed till August 2019. And this is a year-end report for a large plan centers plan. So the reports are always on almost a 1-year lag because there's a lot to do in crunching these numbers. And just to show you some, all right, so there's things about assets, what kind of assets does the plan have, but I want to show you more. All right, so here's like a revenue statement sample. What is their Medicaid premium revenue? That's the capitation rate. And look what we have right here is the PMPM. That's the per member per month. That's how much they get a month plus these add-ons. So we got, 30 of these reports, except not only 30, because this is a statewide report. And a plan like this, Center's plan, operates in many regions of the state. And they are required to file a report like this for each region in which they operate with data from that region. So it wasn't only 30 reports, it was like 100 reports. Well, if you want to just be able to see a list comparing the capitation rates of plans, you can imagine how much work it is to go through all these reports. And that's what we've done, and that's what you're going to see in a minute. But just to show you a few other things, we were not able to visualize everything on these reports. There is so much. But just to give you an idea, here's something we didn't visualize. How many social workers and care managers do they have? This is the number of full-time equivalents. What's their staffing ratio? If we had more resources, this would be a great thing to compare to across plans. We were limited in resources. We were not able to show everything. Here's something breaking down their administrative expenses. How much do they spend on administration? What are some of their contracts? And this is one of my favorites that we did not visualize. What are the salaries of the executive management? Okay, this gives you an idea. 5.7 full-time equivalents, their salaries were 4.2 million. So you divide 4.2 million by 5.7, that's almost $1 million a piece for the top five, the top five positions. This is on a statewide basis. So that would be interesting to post for all plans. So it goes on, and we'll just get into the weeds now but you might want to just take a look at this sample because you'll see a lot more, and we might come back to it after we look at some of this. Then we also uploaded the instructions for how plans fill these out, because there's lots of terminology, of course, in here. And so you might want to see that. We'll look at this in a minute. I mentioned before that plans file a different report for each region in the state in which they operate. So this is the list of the 4 regions and the counties in the region. So as you look at the visualizations, you'll definitely, especially if you're outside of New York City, you'll want to identify which counties you're interested in to look at that right region, right? So, and more about that later. So you can see none of this is intuitive. You'd think the New York metro area is just New York City, but it's not. It's also Long Island, both counties, and Westchester. So when you look at the data, you want to keep that in mind. It's not just New York City. We also have a glossary here, which is just right embedded in here. You can, if there's terms that you don't know, you can click there. But I think, so that's some background, and those are good things just to keep with you when you're looking at this. But let's take a dive right into one of the tables. So I think we're going to start with the hours, because this is the table that first got me interested in looking at this data. The plans report, and I think what I'll show you is what this looks like when they report it. It's appendix. Oh, where is it? It's A6 or A7. We're almost there. Okay, here we go. Here we are. So this is Exhibit A5. You can see what the plans are required to report, the number of member months. We'll talk about that in a minute, for which they authorize 7 different, what I call buckets of hours. So from the lowest hours per month, which is under 80 hours, 1 to 79, to the highest hours per month, which is 700 or more, and each one in between. So what are member months? So you could see the highest number for this plan, Center's plan, was, well, oh no, not the highest. Their highest number was the second lowest hours per month, under between 80 and 160. And their lowest number was the second one. So let's just look at the definition of member months so you understand that, because it's not intuitive. Just going to go to the definitions, and because for me, it's always easier to see something in writing. So plans report much of the data by member month, which is equivalent to one person for whom the plan has recognized capitation premium, has received premium for 1 month. So, and in this case, it's a member month is the plan provided that level of service under 80 hours a month or over 700 hours a month for one person in 1 month. Okay, so why do they say that instead of we gave it to 300 members? We gave 700 hours a month to 300 people. Well, what this does is it adjusts for turnover, because not everybody's enrolled like for a full year. So for them to say they gave 300 members 700 hours a month, maybe those members only got it for 2 months, right? And then they died, or they changed plans, or they only enrolled in the last month of the year. So in order to compare apples to apples, they just report member months. So here's the example. So what we've done here is divided the member months by 12. So if the plan reported providing 700 hours of personal care in 200 member months, for example, we divide that by 12. This would be like 16 member years, and that's a rough approximation of 16 members. All right, so it's not exactly, because some members joined in November and some died and some changed plans. But by using that formula uniformly in every plan, it's a fair way of comparing the plans. So going back, so this is some basic navigation. All of our visualizations are like this. For most of them, you can pick the years either 2018 or 2017. Now, I know you're all muted, but I can imagine hearing some groans. Like, why is this data so old? Okay, well, we started this project when even before, back in like 2019, when only 2017 data was available. And we hit a lot of problems. For one, I was hit by a car and I was out of commission for about 6 months. For another, a thing called COVID hit, and it just sent everything into massive delays. And our own systems were, and we were not able to devote the time to it. And we hit a lot of problems with this. So we did get to 2018 data, even though that wasn't originally planned. But the 2019 data didn't become available till like the very end of 2020, 2021, when we were already very far along on this, and we just couldn't get it. Plus, over time, they change how they release the data. So it's not like you can just get the new data and plug it in. They have new plan codes and different things like that. So it would be a bigger lift to add new data. But I think as a plan to plan comparison, this is all still valid. Sure, we would love to get the newer data. And any ideas for grant funding to be able to, to do that, because this costs money, is appreciated. Send me your ideas. But let me show you, we're looking at the most recent data. We're looking at statewide. Here you can pick either consumer directed, or you can pick personal care, or if you pick all, it combines them. So you're looking at the hours that the plan approved both personal care and CDPAP. Then you could look at the number of member years that, the hard number that the plan authorized in these different buckets. So you see, and like just the sheer number. So the number, obviously is smaller for smaller plans, right? And should be bigger for bigger plans. You can see they're all tiny. So even ICS, which we know gave more high hours, its number of hours of member years giving at that highest level was still very low. But I like to look at the percentages instead, because the percentage allows you to compare apples to apples. It's so a large plan, we know will have more people, so they might appear more. This way, it's the percentage of the plan's members that got 700 or more hours. So here, United Healthcare was the winner, followed by ICS, followed by Fidelis, and then the other plans you can barely see. You can also pick a plan and just focus on it. So I'm just going to pick an upstate plan, and I don't think that even, let's see if I can. If you highlight a plan and you hover over it, oh, there it is, Kalos. The percentage of members who got this amount of care was 0.0074. That I can't even, it's like maybe one person got it for 1 month. That is so little. Whereas United Healthcare was like 7%, ICS was 5 to 6%. So you can highlight a particular plan, and you can also, so you can see like this plan, Senior Network Health, 84% of its members got under 80 hours a month. That's very high, right? And VNA Nescentia, 75% got the lowest number of hours. So you can also look at this just for a particular area. Here's the rest of state. So that those upstate plans pop out more than. And even plans that are statewide, you can look at them here just to see their hours in that region, which is also interesting because they're lower. So you can look at it by region. As I said, you could decide to only look at personal care or CDPAP. And here you can just say, let's say the line graph that doesn't pop so much. Here's another way to look at it. And we spent so much time, John Rodat, who's on the call, and I and other people in our group, trying to figure out the best way to visualize this data so it pops, so it makes the point we're trying to make. And I think I like this graph even more because you can really see, it's the same data, but you can really see, so these are the lower hours on this end, these two, the dark gray and the light gray. And this is the percentage of members of each plan that got those high hours. But these, the pink and the red, are the percentage of plans that got the lower hours. I mean, look at this, Elderwood, they're upstate. It's so few members got anything but under 160 hours a month. So there are, oh yeah, we have, so you get your heads wrapped around, well, what is 700 hours a month? So we just did some math and think, okay, how many hours a week are these care plans? So 1 to 79 hours a month comes out to about 18 hours a week, which is about 4 hours, 4 days. So that's, you could see some of these plans, 80% of their members got that much care. And these are just some sample care plans in these different buckets. I have no idea how the state came up with these buckets. I find them, they're very hard to work with. But live-in is around this like third to the highest bucket. Split shift is definitely the highest bucket. And the second highest bucket is somewhere, it says, to me, it looks like it's split shift, but not 7 days a week. It's we're stuck with how they label these. Now, here's something else I want to show you, okay? Let's say you want to get down a little deeper on this, and you want to, you can download the data. Let's go back to the original. All right, we have a thing here, how to download, share, or sort data. And what happened to our download icon? John, what happened to the download icon? All right, and I'm not looking at chat to see. Beneath is a Tableau logo. Okay, it just might have a little technical glitch here that, or it's a Valerie glitch that I'm not seeing it. But what we have is a sample of a download right on the home page. So I want to show you, and we'll fix that. All right, so when you download the data, this is a download of statewide data. Let's see if I can make it a little bigger for you. It's statewide data, and we can just decide to only look at percentages because that's what it's easier to compare. So you could, when you download it, you could put in filters, but this one is there for you to play with. It's downloadable. And each tab has a different region. So if you're interested in a particular region, you can just look at it. And this shows, with this, you can actually put them in the order. Let's say you want to compare what plan gave the fewest of the low hour cases. You can just sort that. And what plan gave the most of the high hour cases. You can sort that. But what we also did, which, things that you can do with Excel, is just combine some buckets. Well, you think, okay, how about if we combine those two lowest buckets, the lowest two buckets of hours, and let's compare plans that way. So this is, pretty, look at all of these plans that gave more than 80% of their members under 160 hours a month. Now, when you look at them, a lot of them are upstate plans, but not only. Integra is New York City. Senior Whole Health is New York City. This is looking at these numbers. We're then going to look at how much nursing home usage there is. So, one of our recommendations in the report is the state should be publicizing this so that if I'm shopping for a plan, I'd like to know that, how much of an uphill battle is it for me to get 700 hours or even more than 480. So combining the top 3 buckets here, look at that. Only 2 plans gave more than 5% of their members more than 480 hours a month, which is basically, let's see, this is live-in or split shift. Only 20%. 3 plans gave 20% of their members live-in or split shift. The rest are 12 and under. And, it really goes down. So to me, if I'm advising a client, I look at this and say, this plan is not handing out high hour care. It's one of the lowest. So you might try another one where you might have a little better chance. Integra was only 3.85%. So for one thing, the state should be posting this. This shouldn't just be. The other thing that the state should be doing with this is looking to make sure plans are assessing properly. If so few people are getting high hour care, they should be looking at, is this plan putting more people in nursing homes? Is this plan cherry picking and turning down enrollees, discouraging enrollees from enrolling who have high needs, right? So all of those things. So you can look at this for each region, and we'll make sure the download thing, I might just be spacing out and not seeing it. The last tab on this hour one is the changes from year to year. Did the plan from 2017 to 18, did the plan authorize more or less members with each bucket of hours? And this will be more powerful if and when we can add more years to the data, right? Because just a 1-year comparison isn't that telling, but a 5-year comparison would sure be pretty telling. So, I can just take questions on this graph. Were there any questions on this?
looks like we have a few. Someone was asking, does independence mean ICS? And United Healthcare MLTC doesn't exist anymore, correct?
Right, right. Okay, so great questions. Because of this, here's another download that you can do. List of the plans, which shows these name changes and what abbreviations we're using in here. So if you looked up independence, it shows it closed, what happened to it, what name or abbreviation is used in the visualization. So this is another helpful companion. You know, Home First, it's dropped out of a number of counties. It's now called Elder Plan. So you can use this as a companion. You just also mentioned, like, when you see VNA home care, we know that now is an Essentia.
Mm.
So, you know, look, they created a monster of a program, and you're right, United Healthcare closed a couple of years ago. So, but if you looked up VNA, you'd see it's an Essentia. So hopefully this will help you, but it's a great question.
Another question was data collected regarding requests for additional hours and percentage of approvals versus denials?
Wow, great question. Let's see, how do I? You know, that we don't know. I mean, this is the number of hours authorized, and I believe provided. You know, that's a good question to get into the instructions. For that, I would say take a look at the instructions, and I think it's the kind of thing where I think the plans probably are fudging it. I'm not going to take the time to open the instructions right now, but if we have time later, but here they are right on the home page. Now, these are instructions for 2021, but I don't think they've changed in any material way. But you're right, it won't necessarily get at like how many hours is the plan really authorizing. Like, for example, in the last 2 years, many of us who do this sort of work know that plans have been forced to provide 24-hour care, split shift care to a lot of clients that they didn't approve for that, but because of the fair hearing system. A case called Varshavsky class action says that certain people, when they're in the appeal process and they're waiting for their fair hearing, and if they're homebound, if they meet the definition of homebound, so they get a bump in their hours to whatever they asked for until their fair hearing is held. And for them, that can be years. So if the plan's reporting, oh, we gave split shift care to 100 members, we don't know how many of those is Varshavsky. But I'm going to show you where you can see an article about this. If on New York Health Access, if you go to Medicaid and go to appeals and hearings, all right, the right to a home hearing under the Varshavsky case is right here, and you can read all about it and read all about these special protections. But that's a very good question. It is a limitation of what we can really infer from the data, but it's better than nothing. I mean, right now we have nothing. We have no idea. I mean, I can, well, let me go through more and then I can show you like what the state does show is this sort of ridiculous data of how many people are incontinent and how many people live alone. They have that on their Open Health Data website. Okay, so what are plans doing about that? Like, are they authorizing home care? Silence, radio silence, nothing. So they have this data, but it talks about how much, what are the people's needs? It doesn't say how are those needs met. So this is like the state's little dirty secret. But now I want to go on and show you. We looked at home care. Now let's look at other services like nursing home care. Well, so we're looking in the long-term care service mix. And again, I'm going to choose, this is New York City Metro. I'm going to look at statewide. And we can look at all, this is only long-term care services. So this is CDPAP, home health care, nursing facility. And the plans have to report the number of member months who got nursing facility only during the whole reporting period. And the reporting period here is for a year. So that means they were in a nursing home for the entire year. Now in 2017 and 2018, we did have what was called the nursing home carve-in, where if you were in MLTC and you were placed in a nursing home and you didn't come home, you just stayed in that MLTC plan. So that can explain some of this, but you'll see it doesn't explain it all. So let's take a look at what this visualization tells us. And again, I'm looking at here numbers. Let's look at percent. I think it's always most helpful because that way we're looking at the percentage of the members that are receiving. Let's see, let's highlight nursing facility only. So a couple of plans pop out, right? Elderwood, and when you hover over that, it shows you 62.6% of its members statewide were in nursing homes for all of 2018. That's pretty high. Erie, Niagara, 33%. VNA, which is Nescentia, 56%. That's very high. So when you say, oh, this was the carve-in, and this was because nursing home care was carved in, if that was the factor that led to these high percentages, then all of these plans should have had such high percentages, right? Nursing home care was carved in statewide then. But yet some plans, let's look at my favorite, I don't play favorites, but Independence, ICS, had only 1.67% of its members in a nursing facility in 2018. I mean, nursing home care was carved in for them also. And we have a sense, we can use these charts together to figure out why is that? Because they were more willing to approve higher hours of care. And that kept people out of nursing homes. So we're looking at this by plan. And then we can also look at it, just to look at the actual numbers. So this is where the bigger plans show up, bigger numbers, and you can see where the numbers fit in. And we can change it to region. And now this is, so when we just look at New York City, we see some plans were still pretty high. nursing home, Metro Plus, Arch Care, Aetna, but none of them as high as those upstate plans were. Even United Healthcare was high. When we look at rest of state, that's where you see, whoa, and this is half the state in terms of the number of counties, not the number of enrollees, but these are these very high percentages. Okay, so on this one, the download icons are showing up. You see the tableau, and we'll just look into why these weren't showing up on the hour. But do you see this highlights? You can download the data. And if you do try to download it, you get these different options. You can just download this image, and our report is full of some of these images. Let's see, it's not allowing data on this one, but I'll check out why that's the case. All right, so that's the long-term care service mix. I did want to show something else. Where was the region? Let's see. Just another point I wanted to make. If we look at the numbers, you can also change the order of these. So you see the bigger plans and sorry, I'm just looking for something I wanted to show you. Okay. All right, so that's the long-term care service mix. And then we can look at the service expenditures. So that was the number of people getting services. This is the amount of money the plan spent on different services. And this one is not only long-term care services, it's also things like dental, right? You can see this one is showing the percent of the plan's expenditures on all services that were spent on dental care. And that's not surprising. Dental care is not the biggest ticket item. But let's see, like if we look at adult daycare, we can see some plans were relying more on adult daycare. We look at CDPAP. Wow, you can see a lot of plans. Let's see. What I want to do is show you both CDPAP and personal care. And it's interesting to see. So the pink is personal care, the blue is CDPAP. And for some plans, it's about equal between them, right? In some plans, the blue is quite substantial. And I think that's particularly true when we get out of state. Let's see, I mean upstate. So look in the rest of state, just looking in this region. look at the relative amount of blue, which is CDPAP, compared to pink or personal care. So, we've all been saying for years that upstate, they really rely on CDPAP because of the aid shortage. And this shows, yeah, that was true even before COVID. I mean, look at this. Fidelis upstate is almost, 30% of the expenditures were on CDPAP and only 3.7% on personal care. Now, this is Fidelis and Fidelis Care, because this is when Fidelis went through its legacy plan. Honestly, we couldn't quite figure out. It filed all these different reports because it got, bought out. But it's all Fidelis. So to me, a recommendation is, hey, state, instead of trying to undermine the CDPAP program, look at your data and you show that these plans are relying on CDPAP in order to meet the demand for services. So let's make it easier for CDPAP programs to survive. But, and you can see how different it is regionally. Let's see, in this area, VNS Choice, which is a plan that's statewide, 25% of its expenditures were on CDPAP. Let's see what that is in New York City for VNS. Only 4.5% on CDPAP. So, and you could make those comparisons. So one thing to me, but yet if we look statewide, when you mush it all together, VNS is 6.6%. So looking at data by region, you can see how misleading it is to look at the whole state together. Because if you want to really look at the aid shortage and how many people are in nursing homes, you've really got to look at it regionally and not just statewide. And I'm going to show you, let's see. Here, there's an alternate on this one to show by region. So this is a really telling graphic. So the gold is nursing facility, and the blue is CDPAP, and the pink is personal care. So look at how different these regions are. I mean, statewide, you think, okay, 20% of all MLTC members, of all MLTC dollars spent on services were spent on nursing home. And you think, okay, maybe that's okay. Nursing home care was carved in, but that doesn't tell the whole story. In New York City, it was about 14%. The rest of the state, and you go back to that list of regions, 72% of MLTC dollars spent on services, all services, was spent on nursing home care. That's huge. So when the state reports, oh, we're doing a good job rebalancing, we're spending more money, rebalancing is the federal goal of complying with Olmstead. Let's spend more money on community-based care and less on nursing home care. You can see how, if you really want to measure the state's progress on that, you can't just look at statewide data. You have to look at the regions, and you have to look at particular plans. So that's one of the things we called on the state for. Look at, and now we're going to go back to show by plan. Let's bring in nursing home care here, CDPAP, personal care, and nursing home care. It's not a coincidence that these areas these plans that are giving so much more nursing home care are giving that much less personal care and CDPAP. And then if we go back to the hours graph, that they're giving low hours. Because of course, with very low hours, you can't keep people home from the nursing home. And you can't get people home from a nursing home. So the state should be monitoring this, and a high nursing home usage, this is all in our recommendations, should trigger the state to then look under the hood and see, oh, is this plan authorizing anyone for 24-hour care? What, like 0.25%? No wonder people are in nursing homes. We have to sanction them. We have to ask them to justify, why are all these people in nursing homes? So you can see that this is just examples of what's here. Okay, so that's service expenditures. Then we have the consolidated finance table. So this is really, you can see there's a lot of different tabs here. And on this one, you really have to spend a little time with, but looking at it statewide, 2018, this is showing the net income or loss of what was the plan's income, subtract its expenses, both for services and for administration, and did it make any money? Look at this. Yeah, Center's plan made $70 million in 2018. That's a nice profit. Fidelis, 41 million. And we go down, some of these plans didn't make so much, but many of them are smaller plans, so as to be expected. And not surprisingly, these are the plans that lost money. And as someone pointed out, United Healthcare closed. They lost money. ICS closed. It lost money. GuildNet closed. It lost money. And Health Plus, I think, also closed. All our list goes through all of these. Senior Health didn't get closed. I guess it was even bought out. But I don't know. Maybe the company wanted a loss leader. But there's a lot of here with the select metrics. You can make, well, let's see, which am I compare? Oh, this is the revenue tab. So this shows the Medicaid premium, and this is what their revenue is from the Medicaid premium. And let's see. If we go back to the compare plans tab, and we can look at it, there's a lot of let's see. So here's one. I think people are at a total premium per member per month when you go on that. So people always wonder, what is the plan's capitation? How much do they actually receive? And that's what that is. So this way, these are stacked. You can line these up in different ways. These are lined up from highest to smallest. So now this is 2018. We know this is not current. And this is total premium. So that, I think the definitions are in the glossary. So you can see the premiums vary quite a bit. If you look at by region, the premiums tend to be lower downstate, but look at this, VNA and Essentia that put 75% of its members in nursing homes, is getting $6,000 a month, which for an upstate plan is quite high in 2018. And then you could look at New York City, and you see some of these plans that closed. ICS had a high premium. They made their, they went to the legislature and made their case for some, special rate enhancements, but it wasn't enough. GuildNet was high there. The VNS Choice is high. So now plans are not limited to giving services based on the premium, right? They are supposed to give split shift care, 24-hour care based on your need, even if it costs more than the premium. But the way they behave, it's as though they say they can't give services that cost more than their premium. But that is not true, because just like any insurance, if that was true, your fire insurance would never pay out after a fire, because of course they're paying out more than the premium they took in, right? That's the nature of insurance, that the high claims only go to a few people. So there's lots of other things to compare here. How much do they spend on dental care if you're interested in a particular service? How much do they spend on the various combined home care? And here, ICS is a small plan, but look at that. They spent more on home care than some of the bigger plans, because they did approve higher hours. And same for GuildNet, even though those were both relatively small plans compared to some of these other plans. And this gives you the member years, 6240, compared to VNS Choice, 11,000. So look at that. ICS had half the number of members as VNS, but gave about 50% more, spent about 50% more in home care than VNS. So that there's a lot of sort of aha moments here in looking at, just you can get very lost noodling around on this. DME. Okay, look at ICS. We know that they were known for their wheelchair clinic, but look at how much higher they were. So I think I've gone through. So there's one other graph here that I haven't gone through on Medicaid plan enrollment. And John Rodat of Public Signals very graciously allowed us to post this, even though it is from his own website. This wasn't done for this project. So this one, this is all based on the New York State open plan data. Like they have, so I'll just show you what it's based on here. So the open health data, they have this aggregate data set. It's updated very often. Look, it was updated September 23rd. The problem with it, it's really hard to use. I find it hard to use. So what what John's program did was they made it, where is it? Okay, they made it more user-friendly. So, for example, you can look up particular plans. Whoa. And here's the trick, and this is explained in our instructions. This is all plans in the state. This is HARP and Mainstream. This is everything. So since we're mostly interested in MLTC, what we click on is partial MLTC, MAP, and PACE. Those are the 3 types of MLTC plans. So that narrows it down a little. You can also here click on different regions. Unfortunately, the state uses different regions for this than they do for MCOR. And they also don't give us a nice legend to show which counties are in these regions. But right now we're just going to look statewide, and you can follow any particular plan's growth. So I'm highlighting VNS. So VNS Choice, this is, I think, when they were sanctioned for being naughty and enrolled. Remember the social adult daycare scandal when they enrolled a lot of people who really didn't need MLTC? That was early in MLTC. So their enrollment stopped for a while. They were sanctioned, and now they've built back up, and now they're one of the highest plans. But Center's plan has been gobbling up other plans. They're very high. Look at how much they have shot up since they only started in 2013. The next biggest plan is Integra, and we looked at some troublesome data about Integra. Very high nursing home usage, low hours, and you want to look at these things. Health First, which as we know of as Senior Health Partners, so they're now the 3rd highest. And you can guess at your region. Unfortunately, we don't have the legend of what, but we could just look at New York City, for example, and only look at New York. So there's a lot here. There's also demographic mix, which is interesting. One of the things that we've noticed, again, we want to take the plan type and let's just look at partial MLTC for once, at first. And so there's a color legend here of race and ethnicity. And one thing we've noticed that's in the report, some of this just doesn't make sense, but let's just look at like Senior Health Partners, for example. They're 50% Hispanic for their partial MLTC plan. And let's look at their MAP plan, which is Health First. That's almost 68% Hispanic. So this is an observation we've had at NYLAG about why, and I think that this will be true for a number of these plans. Why do these plans seem to attract more Latinx population? Is it marketing? Could it be, unfair or misleading marketing? We're concerned about MAP enrollment because MAP plans don't, for one thing, don't have the Varshavsky protections for fair hearings. So that's, that's a big concern and definitely is detrimental to our clients. So, but it's fun to noodle around on these pages. So I think let's take some more questions.
So Val, just to start with a quick one, you're going over these awesome graphics, which are amazing. But I know we had some questions just about accessibility and alternate formats. So can you just talk about how the data is on the website and can be viewed in different formats? Because I think you mentioned you can download it as Excel and.
Right. Okay. So You can. So when you go here, do you see under each of the visualization, there's a Tableau toolbar that allows you to share, look at in full screen. I guess I could have been doing that. Sorry, I didn't do that because that would have been probably better to make it bigger. But now you know you can do that. Okay,
Yeah.
make it bigger. And you can click on download. So when you go to download, it can download in PDF, PowerPoint, and crosstab. Believe it or not, crosstab, I don't know why they call it that, is really Excel. You can pick Excel or CSV, and it downloads, let's see, that's the one I already downloaded. So here's what I just downloaded. So it will only download like what you're viewing, but you can do a few downloads of different views and then combine them. Like that's what I did on this sample. I downloaded it separately from each tab, New York City, Mid-Hudson for each region, and then did some of this, played around with it in Excel. But like this one's done. That's why we uploaded it. So you can just use this one. This is done and uploaded on the website. So you don't have to repeat what I did on this one.
Mhm.
But this combines personal care and CDPAP. If you want to look at those separately, then you can do it on your own. You go in and download that data. So, someone asked for, I saw one of the questions asking for some of the visualizations on the, that I shared. Most of the things I shared are in this report, and they are just going to a sample, like right here. Okay, so most of them are in the report that you can view with an enlarger, and it tells you where it's from. This tells you where the download is. So I think you can find most of this, in here. Here's that other one. So here's the one, the regional comparison. And again, it shows you the source. You can link on it. So I think that this, this is why we did this report. So you'll have some of these images, already in print.
Looks like we had a question. Was any information collected about reimbursement rates to providers?
That's a good question. I don't think MCOR provides that. MCOR is not you can look at the report yourself, like I said, but you could look at a sample report. I'm pretty sure they don't report actual rates. They're reporting the aggregate. How much did they spend on CDPAP for how many member months, right? Which is a proxy for how many members. So no, it doesn't get into provider rates. That would be good to know, but that's not here.
Okay.
Good question.
And then someone else asked, do you have data from long-term care, home care, personal care approved by counties directly?
No. This is managed care.
I mean, this is already a lot of data, but I'm just
right. No, but you're right. Like once you start looking at data, I know exactly what you mean. You just wish you had more. And that's, you know, that's the name of the game. I mean, you just want more. And the fee for service data, you know, the state used to post all that. They used to post expenditures, a number of recipients getting each service. They stopped years ago. So that's something that so we don't even know how many people are getting personal care or CDPAP around the state from their local districts. New York City posts it. They actually do. I can find that. They post it regularly, which is really nice. But so if
Someone
you
else,
go to the
oh
just
God,
to
I'm
the
sorry.
New York City site, just to show you real quick, they have on from their homepage, NewYorkCity.gov/site/HRA. Maybe I can put this in chat. There's facts and HRA monthly fact sheets that you can see they post these every month. And here's the September one. And it gives you a lot of facts. And on the back, very experienced at looking at this, you see how many home care cases there are. And so this is basically people who are exempt or excluded from MLTC, how many housekeeper cases. And but I don't know that any other counties do that. And it certainly doesn't say how many hours they're giving or how much they're spending on it. So no, I am not aware of any of that data. But great question.
Someone else is asking, are hours that are listed in these charts accounting for the hours that Medicare paid for, but MLT's coordinated? Or is it just the Medicaid funded home care?
Yeah, this is just the Medicaid funded home care. So, you know, it's a good question because it also doesn't account for, let's say, the consumer's daughter provides 12 hours of care a day, right?
Right.
So the person is getting 24-hour care, but the plan is providing 12 hours. But the only thing I can say about that is, since it doesn't provide that at all, we can assume that for all members, they're getting some Medicare home care, they're getting some family home care. So like that should be sort of equal across plans. And so there should still be like equivalent need for people who don't have family to provide care or aren't getting Medicare. So it's still like a valid piece of data to compare across plans. Okay, what is the plan providing, right?
Right. Now, this data obviously only goes through 2018. Are there plans to add to it with more recent data as it becomes available?
More recent data is available, but funding right now
Right.
isn't available. So if you have any ideas for funding, you know, we did this with a data consultant because we at NYLAG don't have expertise in creating these visualizations. And, you know, so it's something we're very interested in doing and updating the data.
Someone else is asking, so a high share of members in skilled nursing facilities all year is a windfall of a plan facing little to no care management expense. Is that correct?
Let's see, a high share of members in a skilled nursing facility all year is a windfall because the plan has little to no care management expense. I wouldn't say that that's a windfall because nursing home care is expensive. And but we can see, like, let's see, we can look at it's easy enough to look at how much do they spend on care management? I think that's one of the data points. Unless I'm wrong, maybe we didn't visualize that. You know, we may not have separated out care management. So, oh, well, this is long-term care. Yeah, I guess we don't. I think nursing home care is so much more expensive than care management that I think that's probably not the case. I think the nursing homes were clamoring to take nursing home care out of the benefit package. So it was definitely costing them more than they save from not doing care management. But I think what will be really interesting to see is data for later years now that nursing home care is carved out. And let's see if, you know, if plans are still providing a lot of nursing home care. And one of the other things we're calling on the state to do is have better reporting on, now that nursing home people can be disenrolled from a plan after 3 months in a nursing home. That should be publicly reported. How many members were disenrolled from each plan every year? And looking at that together with how many hours is the plan providing, that tells a story too. Because the plan is only providing very low hour care, that there's a correlation there with how many members it's disenrolling, because these people can't come home from a nursing home with very few hours of care. And that should be part of the state's monitoring.
I was trying to see when you were showing that graphic that had the services listed, but is there data related to home modifications provided by plans?
You know, that's a good question. I'll have to go back and look at the original report. I don't think we visualized that here. And I don't know if they were reporting that separately. Some things, you know, that's another recommendation we have. Some things they have lumped together in one category. Like, believe it or not, this service, home health care, that includes private duty nursing. That includes visiting nurses and visiting physical therapists or occupational therapists. So, like, you can't tell how many people are getting private duty nursing in a plan because it's lumped together with, you know, just a regular visiting nurse who might come once a month for 10 minutes, right? So, so those are apples and oranges combined. So I'll check and get back to you on that. I have a feeling that might be combined with like this is, it might be combined with one of these other things. Well, like there's other medical services, other professional services, or durable medical equipment and supplies. See, this is where the devil's in the details, right? You have to check the definition of these and the MCOR instructions and see what plans were required to include in those categories. So I don't think there was one, but I'll see if they define that as being in one of these. But that's why we posted the instructions, because there's questions like this that, you know, it's just a matter of how did the state define these categories. Like home health care, I put the whole definition in our glossary because it just troubled me so much that it includes therapeutic and preventive nursing services, private duty nurses, home health aid, rehab therapies, and even the pharmaceutical cost for IV therapies. Like, how misleading is that to include costs of an IV with how much you're spending on private duty nursing, when we know that's a very expensive service that a lot of plans are very reluctant to authorize, and certainly reluctant to authorize in high hours. But it's a great question. We'll check that out.
Well, it looks like we're coming up on 2:30, so we're about out of time. This was very
Okay.
helpful. It's an amazing amount of data in a somewhat digestible way, I think, for lay persons like us. So appreciate you not only making it available, but walking us through how to utilize it. I'm sure you'll be hearing from individuals with additional questions.
So I do see someone asking, can these actual reports be downloaded? No, I mean, just to try to post all of those reports for every region is just, again, it's a resource we just didn't have. I can think about it, whether we want to make a public, like, Dropbox folder or something. I don't know. Can think about it.
Excellent.
All right.
Well, thank you very much, Val. Thank you, everyone, for joining us.
Thank you. All right. Bye, everybody.
Bye.
Thank you to our 2022 webinar series sponsor, Waymo. Waymo is an autonomous driving technology company with a mission to make it safe and easy for people and things to get where they're going. We believe that fully autonomous technology holds the promise to improve road safety and offer new mobility options to millions of people. This is why we're designing Waymo Driver, our autonomous technology to give people a new kind of freedom to go where they want, when they want, while making the frustrations and concerns with driving a thing of the past. Logo fades into view. New York Association on Independent Living.